So I would like to present now, Dr. Kuchler is currently the Associate Professor at the Medical University of Vienna. She did her undergraduate training locally and continued with training in oral surgery and stomatology at the School of Dental Medicine in University of Bern under Professor Buser. From the year 2002 and onwards, she's received multiple awards, including first prize in basic research competition at the EO meeting 2010, Osteology Research Prize 2013, and the Rudolf Slavicek Prize in 2014. Dr. Kuchler has 23 publications and is also author of a chapter in dental literature, and she lectures on topics such as guided bone regeneration, aesthetic implant dentistry, and continuously mentors students in different programs at the University of Vienna. It's my honor to welcome you here, and I'm just going to switch so that you have your presentation, and the stage is yours. Okay.
So, thank you very much for the kind introduction. Dear ladies and gentlemen, I'm very happy to be here and to welcome you at this session today. I'm very happy that Paul was my pre-speaker. I got to know him yesterday, but when I look at the slides, it's the perfect matching of what I'm going to present you. As you just heard, I'm in academics and I'm a clinician, I'm an oral surgeon, and I thank you very much for your confidence in our expertise as oral surgeons. And when I say you load the implant, you load the implant. So that makes me really happy that I see so much trust in the oral surgeons. So the topic of my presentation is implant stability in compromised situation, and that's something I deal with for the last 15 years through my diploma work and all my research work. When I was preparing for this conference, I did an extensive search with one of my diploma students, and I really want to thank him because he spent a lot of effort. And when you go to the PubMed search and you look for implant stability and dental implants, you currently find about 2,500 titles. So we cut it down, and finally we ended for randomized controlled clinical trials, which are prospective studies. We only found a few, but I put together in my presentation what was the conclusion of all these studies and how it might have an impact in your daily practice. We will talk about primary and secondary stability, as Paul has already highlighted it. I talk about bone quality and bone quantity, the surgical skills, which are also very important for the primary implant stability and maybe also for your implant outcome, the implant placement procedures and loading protocols, and implant design. And last but not least, I will talk about the implant risk factors from a systemic point of view, which is osteoporosis and diabetes. So, when you do implant stability measurement, and as Paul has already highlighted it, it's a very effective tool for your screening, and it's also a very nice tool just to communicate your referring dentists like where we are in healing. And it's also a very good tool just to see if an implant is on the risk to fail, if this bungee dip is just starting and where you are in healing. As Paul also highlighted, the average age of our patients is getting very high, and people really stress in very fast loading protocols. So I think this is a perfect tool to communicate not only to the dentist but also to your patients. When you look at this slide, this is what you find at the Osstell homepage, and it just reflects which numbers of implant stability you try to reach and how this influences your loading protocols in the long run. So, osseointegration is a dynamic process, and the courtesy for these pictures here go to the Viennese group under the lead of Professor Gruber, where you can see how implant healing starts at day 5, 10, and 15. So with all the development the last years, we are coming to the to a process, we can speed up the healing, and we can speed up maybe the loading. And when you look in details from the histology, you see like on the very left, day 5 and day 15, you see that there's really fast things going on here on the implant surface. And you will see this implant stability graph maybe also in the next presentation, but as Dr. Rosen already highlighted, there's this bungee dip. So after a few weeks, the secondary stability takes over primary stability. And I think to visualize this with an implant stability measurement is very crucial for implant success. So how does bone quality and quantity influence our implant healing or implant stability? So I put together the classification of bone quality, and the most common one is the one from Leckermann Saab that you might see like very often. And just to complete it, there's also Linkoff 1 to 3 and Misch 1 to 4. They're quite similar. And when you put all the literature together, you see that primary stability is influenced by the bone quality. Where do we find the bone quality? Just for your repetition, you can see in the maxilla and the mandible that when you go to type 4 classification, you find it in the posterior maxilla. And this is one of a very critical region, especially in implant stability and also in secondary implant stability. And back in my time in Bern, I did a very nice study together with Professor Buser in simultaneous sinus flow elevation and implant stability measurement, looking at the loading protocols, if we can shorten the protocols, and you will see these slides a little bit later. But just to bring you back in your mind, which are the critical anatomical regions, and just to refer on Paul Rosen, he showed implants like in the upper jaw, which really had a hard time to catch up with the implant stability. Just a very good example for this slide. Professor Lang, Simon Lang, did a very nice study on bone quality and implant stability development, and I really like to cite it because you can very nicely see like how in different bone qualities the increase of implant stability happens. And I think what is also very nice is you see in the bone type, in the type 2 bone type, you can see that you start with high implant stability. You have this bungee dip. I have to ask Dr. Rosen afterwards if this is a scientific expression, because I will now include it in all my lectures because I really like it. And it's good for my Australian friends. And you can see here, and I leave this slide just that you see how implant stability development happens in different anatomical sites. So when we go to the anatomy, again for bone quality classification, we know very clearly from anatomical study, cadaver studies, and also from studies with different bone qualities that there's a strong correlation between the bone density and the implant stability. And it's the same like when you look at the cortical bone thickness, it's also positively associated with implant stability, which means like when you have a high cortical or a very wide cortical thickness, then you achieve higher implant stability. As I mentioned, I started in Bern, and the Bernese group do a lot of implant stability measurement, and they could shorten the implant healing periods based on scientific research. And you can see like that in this study they loaded the implants after 3 weeks, and they had 100% success rate after 6 months, and 96% of the implants in the posterior mandible could be loaded after 3 weeks, which is really incredible for this time where the implant healing period was like 3 months. Very important also to look at the results in the long run, and they did the examination after 2 years and still had a success rate of 97%, which is quite high. and which is a very good argument also for our patients. And again, when we measure the implant stability, we have a very good confidence in loading implants very early. When we come to the critical side, which is the posterior maxilla, as I told you, I was very blessed to do this study with Dani Buser in 97 patients with simultaneous sinus flow elevation. And just to make a comparison for you, there was a similar study by Markovic et al. 2011. They did the simultaneous sinus flow elevation with osteotomes. What you see from the primary stability, that was quite nice and high. In Markovic, it was 59 ISQ, and in our study, it was 68. We had the threshold, or let's say, what we did in this study, we left the implants to heal for 8 weeks, and we did another implant stability measurement. And as you can see from the comparison with the other studies, the red line was the Kuchler study. We went up to 73 ISQ after 8 weeks. And Markovic left the implants heal for 6 weeks, and he came up to 67. So what you see is in all implants, you had a nice increase. And what you also see is that the tool really gave you the confidence to go for earlier loading. Finally, in our study, after 8 weeks with simultaneous sinus flow elevation, 83% of the implants could be loaded based on the threshold level, which was 70. I mean, and 70 is really high. And so 83% was an astonishing number. What you can also see on the graph is that there are two lines which really had a prolonged healing. And when you analyze the patient behind the line, you see that these were two edentulous patients, two female, and we left the implants to heal after 18 weeks, but we were confident just in the increase of implant stability that we could load these implants after a period of 18 weeks. And after 1 year, there was no implant failure, or the implant failure was not in these patients. The implant failure after 1 year, as you saw, was in a patient who lost a buccal bone, but he reached the implant stability of 70 and more. When we go to the bone quantity, I also want to cite a very nice study from Bern because it's very clear, and it's a dog study. I have to apologize, but what you can see that marginal bone level, when it's decreasing, that it has an impact on implant stability. And I think this is also a very nice study just to show what you can do with implant stability measurement, also in the long run, just to estimate like how is your patient in healing or in complications. Another topic which also influences primary implant stability, and sometimes it's very critical to talk about it, but these are the surgical skills. And there's a very nice study on my colleague, Michi Bayer, he's from Graz, and they published 10 years ago a study on the precise drilling, and they showed nicely that the relevant factor was the surgeon's experience. And when you go to a recent study of Romanos et al., I really like it. He had master clinicians and good clinicians comparing with non-experienced surgeons who just got the drill the first time in their hand. And they showed highly significant differences between the clinicians and the non-experienced surgeons. And there was also a significant difference, not highly, but significant difference between master and good clinicians. So very interested. And another factor or another argument that you say education is a very, 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 very important topic for implant placement and also for the long run in success. Implant placement and loading. So we were really focusing on prospective studies, measuring the implant stability and the loading time, and we found like 4 studies which fulfilled the criteria for including in our systematic review, and we found like 30 immediate implants and 32 late implants, and 97 and 96 underwent immediate loading, and it was no difference if you go for immediate or a delayed implant placement. The implants were stable also after loading, so the timing of the implant placement did not influence the implant stability. When it comes to immediate loading and delayed loading, so the dark blue line is immediate loading, which was like the implant was placed and loaded. You can see that when you underwent conventional loading, which means that in the graph the light blue starts after 3 months, you can see that when it's loaded, immediate loading, you see that there is a decrease in implant stability after 2 weeks and 4 weeks, which is significant to conventional loading. And again, this is the confirmation of the bungee dip, or the time when secondary implant stability takes over. So, as you see, you really have to think about these, I would say, critical time in implant healing, which is like between 2 or 4 weeks. What about bone augmentation? And Paul Rosen showed a very nice case with this GBR technique. And when you go to the literature, it's very hard to find a lot of studies on bone augmentation procedures and implant stability. But this one, I think, really nicely highlights that when the patients underwent ridge split, a ridge splitting, that after 3 months there's a little decrease in implant stability, and at this time the implants catch up. And I think it's very nice to show this slide after Paul's slide with this implant case where he did the simultaneous bone augmentation, because I think that implant stability behaves a bit different when we also do bone augmentation. And again, for me, this is a very critical situation, and that's why the implant stability measurement at this time is a very good tool. Well, last but not least from this group, the implant design. When we go to implant design, there was a lot of development in the last years on the market. And again, I want to highlight the study by Romanos, where he did the study with parallel walled implants and tapered implants, and it's a study with the clinician master, good and non-experienced. And when you look at the result, you see that parallel walled implants had lower implant stability than tapered implants overall. There was a significant effect in implant design in clinicians, which means the more experienced ones reached high implant stability also with the parallel walled implants. And the master clinician achieved also high implant stability in TNP implants. So, which means like that when you're experienced, the implant design does not make a big difference. But when you're a beginner, the tapered implants really give you more, I would say, excuse more of your, or gives you more from the learning curve. When we go to a recent study by Lozano, we see the tapered implants had no correlation between implant diameter and implant stability. And in cylindrical implant, we had a statistical significant correlation between the implant diameter and implant stability. Well, in the study back that we did in Bern, we didn't find the difference between implant diameter and implant stability. And we could show a weekly, but we did not reach the level of significance, a weekly correlation with the bone width. So Coming to the second part of my presentation is about osteoporosis. When you are in private practice for a long time and were in the implant business for a long time, you know that there were big discussions in the last years on osteoporosis and diabetes. And the current literature says that osteoporosis has an impact on implant stability. And this is a very recent study which nicely shows that you don't reach the same implant stability in osteoporotic patients than in the control group. But when you look at the survival rates in this recent review, which was published in 2018, you see that there was no difference in implant survival rates. So I think this is the result of what we learned in the last years, and maybe the implant survival rate is in the literature at a very good level because we learned the last years from anatomy that osteoporotic patients might have a risk of implant failure. And again, I think like that the monitoring of implant stability is a very effective tool in these patients, especially when we know that they're compromised on implant stability, to choose the right loading protocol. So when we go to diabetes, as Paul has already mentioned, the literature is very contradictory. And this is a recent systematic review from 2014, published in the Journal of Dental Research. And what you can see here, the conclusion is that diabetes did not significantly affect the implant failure rate. So when you read this, you think like, what did we do 20 years? Because 20 years ago, diabetes was a contraindication for implant placement, and then it went up to, it's a moderate contraindication. You really have to screen the blood glucose levels. So what they also write in the systematic review, which you read on the button, is there are a lot of confounding factors, and we really have to interpret these results with caution. I think something that really makes me confident when you look at diabetes and implant stability is this study by Osstell. And I have to say they did not lose an implant, but what they nicely showed was that blood glucose level had an impact on implant stability. When you look at the graph in the right corner at the bottom, you see a very high blood glucose level, which means a HbA1c of more than 10%, which is really a very uncontrolled diabetes. And you see that this spongy dip is very severe at the very beginning. So I think what we can learn from this graph is that diabetes is having a negative impact in implant healing, and that we should really think about this in our loading protocols. So finally, I come to the conclusion that bone quality and quantity is having an impact in implant stability. The same is with the surgical skills. The more we advance, the higher the implant stability gets. We have very tool in implant placement, not in implant placement, but in implant loading. We can really screen the time of implant loading with consequently implant stability measurements. The implant design also is having an impact, and from the systemic implant risk factors, we have to be aware that osteoporosis and diabetes is currently having a prolonged healing period, and that implant stability is not the same like in systemically healthy patients. So with this, I want to thank you for your attention, and I'm very looking forward to the Q&A questions on the topic.
Thank you so much for that very, very nice overview of the current research, what's available surrounding the risk factors and the factors that are leading to implant stability. And there are questions coming in from the audience, so yes, I think I will push some of you during the Q&A in the end.